And I'm Renda, a board certified OBGYN, and I'm also Rachel's mom. And Rachel, I am super excited about this episode because this is the episode where we're going to talk about all of the routine prenatal tests that you get done when you go see your doctor when you're pregnant, right?
Exactly. That's right. When you're pregnant and you go in for prenatal care, there are a bunch of tests that get done on you and they're routine. But many people don't know about all of these. What are they for? Why do we do them? So that's what we're going to talk about.
Right. So in this episode, I'm going to break down all the things for you. So I'll break it down by trimester. You're going to learn why the tests are done and what the results of those tests can really mean. In this episode, we're going to specifically talk about tests that are done in the first trimester, or even more specifically, tests that would be likely to be done at that first initial OB visit.
Perfect. Perfect. So one thing I want to say about prenatal tests and really all tests in general that you get done is that these days most health systems will have some sort of electronic medical record, most, where you can access your lab results. Very few will, still do paper charting, but most, especially hospitals that you go to, are going to have some sort of electronic medical record that has some way that you can also access those by app or by a portal of some sort. And, I think you'll agree, Mom, that, we highly, highly recommend, then suggest that you register for any type of electronic medical record system where you can get access to lab results. One, you'll be able to look at information whenever you want, and it's your information. So you want to be able to have it and look at it. But, it really comes in handy if you go between different places, like if there's two different hospital systems in your area, or if you move somewhere, or if you're traveling when you're pregnant and, on accident have the baby in a different place where you
On
meant to have the
accident.
baby. Yeah, I've
It
seen
can
that
happen. It does
happen.
happen.
It
Right.
happens. And even when I moved here to Colorado, my OB provider asked me when the last time I had a pap smear was, and I was able to look that up on my previous um, app for where I had it done before and show her
Right.
exactly here were the results, and she read it right off of there. So that was really nice. So, you can access all of that information, the results of your lab test. Sometimes you can even get notes that your provider wrote in
Right.
the computer, and that can be really, really helpful. So, for sure, I think it's a good idea to register for that and have that on hand.
Right. And these days, actually, by law, every patient is entitled to get their results of their tests. And that happens almost immediately. And sometimes patients get their results even before their doctor has had a chance to see them or review them.
Yeah.
Uh, so I say,
Yeah.
yes, register for the online access to your records, but be mindful that if the results come back and you have concerns, give your doctor some time to respond. I mean,
Yeah.
we can't respond to things right away. Sometimes lab test results pop up in the electronic medical record at midnight or weird
Yeah.
times whenever the lab is running those tests, right? And also, I find that a lot of the results, they end up going to my staff's inbox first so that my nurses can sort through them before I even see them. So as a patient, you are very likely to get your results before your doctor does, right?
Yeah, exactly. Exactly. So just wait until the next day. Give them a little
Yeah,
bit of time to see those results. They can't address or respond to results that come back immediately. Like if your doctor's
right,
sleeping
right,
or in a
right.
delivery
We do
or,
we do that.
yeah,
Also,
sometimes.
yeah. And, also, I often get calls from patients who've seen their results and then they get concerned because some of the values are flagged. So please do not freak out until you talk to your doctor. Your results may actually be in normal range. For example, a complete blood count that includes WBCs, RBCs, platelets, white blood cell indices, which are different types of white blood cells. So WBCs are the types of, or white blood cells, they're the type of cells in your blood that are involved in responding to infections. They fight off infections. So sometimes I might get a call from a patient who's concerned because their eosinophils are high. Well, those are the type of white blood cells often involved in allergic reactions. So, like maybe it's hay fever season, right? Or maybe they've been exposed to some type of allergen. So, if the value is only slightly increased, that can be normal, a normal response to you being exposed to some type of allergen. It does not mean you have an infection. And that's just one example. The normal values are typically an average normal range, but a slight increase or decrease may be okay for some of those values.
Exactly, exactly. And especially with kids
Right,
values aren't the same as adults. And a lot of times labs will give you the normal range for adults, not for kids. So, I get a lot of parents calling, freaking out
right,
over a lab results that sounds
right.
abnormal, but if you think
It's
about what
not.
it is for kids, it's not.
And
Um,
also and also sometimes it's, a man's results are different than a woman's, and the
yeah,
lab results are often the male's normal values, not women's.
yeah.
And then when you're pregnant, your normal range changes also, right? So, yeah,
Yeah.
so don't freak
Yeah.
out.
So
That's
just
the
don't
thing.
freak out. Exactly.
Right.
When I was pregnant in my first trimester, I had my first ultrasound done, and the results came back at midnight to my phone. Like I heard my phone buzz and I looked at it and it said, "You have a result." And of course, like I'm pregnant. And so I was like, "Oh my gosh." So it woke me up and I look at it and it said, "You have a fibroid and now you have to go see maternal fetal medicine." And I was like, oh no, like I started freaking out. It's midnight. I can't get a hold of my doctor, anyone.
Right,
And
right.
even me, I start Googling things. What does a fibroid mean?
I think you
At
texted
midnight.
me. I think you
Yeah,
called
at
me.
midnight. I'm sitting there on my phone, like, what in the world? So, don't do what I did. Try not to Google things. It's
Right.
never good. You never find out good information from Google. Just stay calm and wait to chat with your doctor about the results. And if you have a lot of anxiety, especially about medical things, maybe turn the notifications off for that app so you're not
Right.
notified right away. And maybe your doctor can, chat with you when they come in. But yeah, if you have concerns, just talk to your doctor about the results. But all in all, it's really great that patients have access to all of their test results. So there's no
Right.
confusion and no missed results. I
Right.
think it's good.
I agree. So, let's get into the different tests that are done.
Yes. So I remember my first initial visit in the first trimester, I got a lot of lab tests done. So
Right.
let's start there. What are the lab tests that are done routinely at the first visit, and why do we need them?
Okay, all right. So I'm going to go through them in no particular order. Just these are the tests that are standard and are routinely done in the first trimester for all pregnant women. And the first one is a complete blood count. That's called a CBC. And a complete blood count counts the number of different types of blood cells in your blood. We focus mostly on the red blood cells, the white blood cells, hemoglobin, hematocrit, and platelets. So the red blood cells are the ones that carry oxygen. They carry oxygen from your lungs or oxygenated blood from the lungs to your body, to all the cells and tissues of your body. And white blood cells then are the ones that fight infection and disease. When they're elevated, that can be a sign that there's an infection going on. Hemoglobin is the actual oxygen carrying protein that is in red blood cells. And then hematocrit is the percentage of red blood cells in the blood. So those two numbers are very closely related. Hematocrit is roughly 3 times what hemoglobin level would be. And then platelets are the type of cell in your blood that are involved with blood clotting. They stop you from bleeding. The things we get concerned about, especially, are low red blood cell count. That's anemia. And that's going to be reflected by low hemoglobin and low hematocrit. And in that case, you may be prescribed iron to help bring your blood count back up, to bring those numbers up. Iron is needed to make hemoglobin, the protein that is in red blood cells that carries the oxygen, right?
Exactly. Yeah, exactly. I was a tiny bit anemic and my doctor recommended iron for me.
Yeah,
Yeah, I know in pregnancy anemia is really common.
right,
It happens when a woman is pregnant, her blood volume increases significantly to support the pregnancy, and much
right.
of and much of it is fluid volume increase. So the
Right.
blood is actually more diluted. So that's why you see that. Plus, red blood cells turn over about every 120 days. Their lifespan is 120 days. So new red blood cells have to be made to replace the old ones. So when your body is busy growing a new human, it can be hard to keep up with making new cells. Also, your
Right.
iron levels can drop. You're growing a baby's blood cells too, and you need to make new blood cells of your own. So your body is really working hard to keep up. And that's why a lot of women end up needing extra iron when they're pregnant to keep up with that. Just like I said, I had to do that.
Right, exactly. Okay, and then platelets. Platelets are the blood cells involved in blood clotting, and a low platelet count can mean that you may have some issues with blood clotting. There are some conditions that can develop during pregnancy. There's specifically a condition called ITP, or idiopathic cytopenic purpura, where you have low platelets in pregnancy. There's also gestational thrombocytopenia. That's another one where you have low platelet counts in pregnancy. And typically that doesn't show up until later in pregnancy, but it's something that we like to keep an eye on because there are some things we can do to increase your platelet count numbers before you get to birth, right?
Yeah. Yeah. And everyone who's given birth knows there will be some bleeding associated with
Right,
delivery, whether
right,
it's vaginal or cesarean. So you
right,
want to make sure you have good platelets.
right. We don't want you going into your birth having a low platelet count because that's going to significantly increase the chances of you bleeding and losing more blood during your delivery.
Yeah. John, my husband, he is a CRNA and he does epidurals for deliveries. And I know from chatting with him that they also look at that platelet count number to make sure you have enough platelets to clot after an epidural. Because, if you have higher risk for.
Yeah. I know that they won't even attempt an epidural if your platelet count's too low, um, because you can have bleeding into your spinal canal, which is really bad. Okay, so next up is blood type. This test is for whether you have type O, type A, type B, or type AB blood. And your blood type is determined by the presence of certain antigens. Antigens are protein molecules on the red blood cells, and those antigens can trigger an immune response if they're foreign to the body. So let's say you have type O blood. You don't have these antigens on your red blood cells. If you have type A blood, then you have the A antigen on your red blood cells. And if you have type B blood, then you have the B antigen, and AB blood, you have both the A and the B antigen, right?
Yeah. Yeah, exactly. And that becomes really important if you need a blood transfusion, right?
Right, right,
So if you have type O blood, you can only receive type O blood.
right,
Because if you have type O blood and you receive a transfusion with A blood, the person with type O is going to recognize that that A antigen is foreign and attack it.
right,
And then, so the person with O blood can't receive A, B, or AB. They can only receive type O blood. But on the flip
right,
side, a person with AB blood can receive blood from anybody.
right,
They have the A antigen and the B antigen. So if they get B blood that has the B antigen, their body won't recognize it as a foreign substance. But then, O blood has no antigen, so everyone can receive O blood. So that's the difference, kind of between O, AB, and AB blood. AB
right.
and AB blood.
Right. And we also look at the blood test to determine whether or not you have the RH factor. So RH is another protein that can be present on the surface of red blood cells. Most people do have the RH factor and are therefore RH positive. If you don't have the RH factor, then you're considered RH negative.
Right. So the combination of the two results in giving us the 8 most common blood types are A positive or A negative. The positive or negative meaning RH positive or RH negative. B positive or B negative. AB positive or AB negative, or O positive and O negative.
Right.
There are some other antigens that we look for that are more rare, but in general, your blood type is going to fall into one of those big categories first.
Right. So if you're Rh negative, this can cause problems in pregnancy, specifically in second, third, fourth, and subsequent pregnancies. Because if you happen to be Rh negative and your partner happens to be Rh positive, which most of the population is, then there's a chance your baby could also be Rh positive. There's a possibility that the baby is Rh positive because they get their genetics of what their blood type will be from both the mom and the dad. So the dad could make them Rh positive.
Yeah.
And if those Rh positive blood cells get in your bloodstream, that can be really bad because your blood's going to recognize them as foreign. And that is most likely to happen around the time of delivery, or if you have a trauma at some point during your pregnancy. So if those Rh positive blood cells get into your Rh negative bloodstream, your body recognizes them as foreign and attacks them. And it's going to create something called antibodies that will attack the Rh positive cells. So when that happens, it's in future pregnancies. If you have another baby who's Rh positive, then your immune system is already revved up and ready to attack anything that is Rh positive. And your antibodies can actually cross the placenta. So they're going to go
Yeah.
across the placenta and attack the blood cells of your new baby in a subsequent pregnancy. And that can cause severe anemia. It can be quite catastrophic, actually. So, in order to prevent that, we routinely give something called RhoGAM during pregnancy if you're Rh negative. And what that does is RhoGAM essentially binds up any Rh positive cells very quickly before your blood system can recognize it and attack it. So RhoGAM is generally given twice, once toward the end of pregnancy in the third trimester, around 28 weeks, and that will carry you through to birth because that's going to be the most likely time when there's mixing of mom's blood and baby's blood. And then right after birth, it's given as well. We also give it anytime there's bleeding during pregnancy because that can also increase the chances of a mom and baby's blood mixing, right?
Yeah. Right. So only moms who are Rh negative need RhoGAM, and
Right.
only if their baby is Rh positive. But what if we know that the baby's dad is also Rh negative? So do
Yeah.
we need to give
Well,
the RhoGAM
historically,
still?
historically, we've given a RhoGAM to all Rh negative moms, regardless of dad's blood type, because sometimes there can be questions about paternity. But now we can actually test baby's blood type in utero. And if baby is also Rh negative, then mom does not need to get the RhoGAM. And recently, this has become important because just recently we've had a nationwide shortage of RhoGAM. So we really want to only use it when we absolutely need to use it.
Exactly. Yeah, exactly. Another reason your blood type is super important and why, as pediatricians, we want you to get it during pregnancy is so that we can take care of your baby. Because just like certain blood types will attack other blood types during a blood transfusion, like we talked about, your blood can also attack your baby's blood in utero, sort of like you were saying with the Rh negative versus positive.
Right.
And if that happens, then the newborn has something called hemolytic disease of the newborn, or erythroblastosis fetalis. It's pretty rare in the US these days since we have protocols and set standards that can decrease the risk, like giving RhoGAM to Rh negative moms.
Right.
Um,
Right.
but yeah, so it only occurs in about 4,000 babies per year across the entire US, but it's very serious and it can be fatal. Um,
Mhm.
it can cause anemia in the infant, like you said, jaundice, like we discussed in last week's episode,
Yes.
liver and spleen enlargement, a disease, and also, a disease called hydrops fetalis, which is essentially heart failure and fluid swelling that can be fatal. So, if you have type O blood or Rh negative blood, your pediatrician, if we don't already know baby's blood type, will obtain the baby's blood type after delivery to evaluate the risk on the baby. And like we talked about, having incompatible blood types puts the baby at higher risk for jaundice and hyperbilirubinemia. So if the mom and baby have this issue, we will usually start phototherapy, the treatment for jaundice, sooner similar will have lower thresholds to start lights than a baby whose blood type is the same, because this puts them at a much higher risk of having jaundice.
Right.
So,
Awesome. Awesome.
yeah.
Okay, that was good information. So, next up, the next test that we do during pregnancy routinely is a test for rubella. So, rubella is also known as German measles. And when rubella infection occurs during early pregnancy, there can be serious consequences like miscarriages, stillbirths, and a constellation of severe birth defects in infants can result. So, due to the severity of the illness for the baby, it's standard of care to check to see if a mom has immunity to rubella. And that's done for all pregnant women.
Yes. Yeah. So German measles, like you said, which we also call rubella, can make a baby very, very sick if mom is infected with this during pregnancy.
Yeah.
The risk of congenital infection and defects is highest during the first 12 weeks of gestation while the baby is first developing. And, if she gets infected with it later on in pregnancy, it's not, the risk goes down for having congenital rubella. But so like after that 20th week or later, the defects are pretty rare. But common congenital defects of this disease include cataracts, congenital heart disease, hearing impairment, and developmental delay. These infants can present with all of these signs, the cataracts, congenital heart disease, but the most common one is hearing impairment. And so we might just see that. They also have a rash that is seen in other infections as well that can come congenitally like this, but it's reddish blue dots all over the body, which they've nicknamed blueberry muffin baby because they
Oh,
look like a
no.
little blueberry muffin. I know, it's sad. There was actually an epidemic of rubella in the 1960s, and a lot of babies were born with congenital rubella and had this rash, and that's where we got the name from. So like I said, you can see this rash in other infections, but rubella is where it got its name.
Okay, and the 1960s were not that long ago, everybody, okay? So,
No.
I was actually alive during the 1960s. So, thank God for vaccines that we have pretty much eliminated this scary congenital infection. But
Yeah,
I wanna say
exactly.
there's more and more people who are anti-vaxxers who are not vaccinating. I know in our community, there's a big group of people that don't vaccinate at all. So, I predict there will be a resurgence of rubella. So
Yeah.
it's really important to make sure you get your vaccine to protect yourself and your baby, and that you get tested during pregnancy. Yeah.
Exactly. Yeah. I've actually never seen a case of congenital rubella. And, that's all thanks to routine vaccinations. We'll do another episode where we will chat more about vaccines and our opinions on them and the evidence behind them. But rubella is included in the MMR vaccine that children get at 1 year of age and 4. And, we're already seeing cases of measles because people aren't getting vaccinated. So it's
Right.
definitely
Right.
possible that we will see rubella in the near
Right.
future because of this as well.
Yeah, and that is what the blood test that we do during pregnancy checks for. It checks for whether you've been exposed to rubella before, either through infection or through the vaccine. And we can't really tell the difference. It's just, do you have the antibodies? We can tell that you've been exposed to it from those antibodies.
Yeah, so the vast majority of people are vaccinated against rubella in childhood. Like I said, it's part of the MMR vaccine. But if for some reason you've not been exposed to the vaccine or the vaccine was ineffective, then you will see on your results it's going to say rubella non-immune. And you should definitely receive the vaccine after pregnancy if you are non-immune. Some people that did receive the vaccine when they were younger don't have sufficient immunity when they become adults. Maybe it's been a while since you were vaccinated. So if you test non-immune, that just means that you should get a booster or if you never had a vaccine, get the vaccine after you deliver.
Right. And we don't give this vaccine during pregnancy. We give some vaccines during pregnancy, but not this one because it's a live virus vaccine. And we do not do any live virus vaccines during pregnancy because that actually increases the chance of getting the infection from the vaccine.
Exactly. Yep. Okay, so other tests we do, we check for hepatitis B and hepatitis C. So let's talk about that.
Yeah. Yeah. So hepatitis B and C are both infections of the liver. And when you have hepatitis B or C, you can potentially pass it on to your baby. Now, most folks, or many, are vaccinated against hepatitis B because it's one of the childhood vaccines in the series that's been around the last few decades. But there's no hepatitis C vaccine available. A lot of times when a person is infected with hepatitis, they don't even know that they have it. They don't have symptoms, especially in that initial period right after infection. So, this is why we just check everyone.
Exactly. Yep. If we catch a person that has hepatitis B during pregnancy or delivery, we will give the baby a vaccine and sometimes another injection right after delivery to prevent that passage of the disease to the baby. If a mom has hepatitis C, we're going to follow that baby. There's no vaccine, like we said. So we'll
Right.
follow that baby very closely after delivery and provide treatment if the baby ends up also being positive for hepatitis C.
Right. So we actually check numbers so that we can prepare for and make sure the baby has the best options available to not get hepatitis after birth. We can monitor titers of how much of the virus, viral particles, are in the mom's bloodstream. We also want to monitor any issues with mom's liver function during the pregnancy as well. And we check for other infections that can be bloodborne, like HIV. Um, that's
Yep.
another infection that's
Um,
routinely tested for in all pregnant women. And I want to say this because sometimes I'll have pregnant women who don't realize they're going to be tested for HIV when they're pregnant, and they're a little bit offended that I tested them for that. What do I think about them? But it's not
no, we test everyone.
okay. We know you've had sex, you've been caught. You're pregnant. So so everybody gets tested for HIV in pregnancy. It's just routine, right?
Yes. Yep. Every single woman. And that's with a blood test. And, the reason we screen for that is because if a woman is pregnant with HIV, she has a really high risk of passing it on to her baby. And, just like hepatitis, there's a short period of time when you can be infected and not have any symptoms.
Right.
So we check everyone just to be safe. Rather be safe than sorry. There are medications that are available that really greatly reduce the chances of passing HIV to the baby. This is, one of the really modern miracles of medicine. The medicines that have been developed to treat HIV, they're amazing.
They
We
are.
can't cure HIV, but we keep the viral numbers to levels that are essentially undetectable. And with really low viral load counts, you have a lot less risk of passing HIV to the infant. Um, you know, even with, but I will say, even with low viral counts, we still give the baby treatment for HIV infection after birth if mom is positive. All of this we do to keep the risk of passing HIV to the baby is really, really low, essentially zero.
Right. So women with HIV can still have a vaginal birth in the US because of those amazing medications, right? For a
Yeah.
while, we were
Yeah.
recommending a C-section for every woman who had HIV, but not anymore. Now we screen for HIV because there are very good treatments available for it. We also check for some other sexually transmitted infections. The main infections that we check for are syphilis, gonorrhea, and chlamydia. Now, all pregnant
Yeah.
women are screened for syphilis, and that is generally, it's been mandated by law that all pregnant women are screened for syphilis, and that's done by a blood test. And the reason we check for syphilis is because syphilis infection, specifically congenital syphilis, where a baby gets syphilis from a mom, can also be really, really devastating. Yeah.
Yeah. Yeah. It's awful. Babies with congenital syphilis can be born with deformed bones. They can be born blind, deaf. They can have anemia, enlarged liver, enlarged spleen. They can get meningitis. And then, like we talked about, they can be jaundice and they can have skin rashes. Some babies are not born with any symptoms, but if it's not treated, they can develop these symptoms later. They can have seizures and developmental delays, things like that if the syphilis isn't properly treated and it just is allowed to continue. And it can also be fatal for babies. It causes miscarriages, stillborns, and even death after delivery. It's really unfortunate, but the number of babies born with congenital syphilis in the U.S. has increased
Yeah.
unfortunately, over the last
Yeah.
decade. Um,
Yeah.
in 2012, the number of babies born with congenital syphilis was 334, 2012. And in 2022, just 10 years after that, it's now 3,761. So, that's a really big
Yeah, that's
increase,
a
a
huge
thousand
increase.
percent increase in 10 years. And 300 of those babies included in that 3,000 from 2022, they either died after delivery or were a stillborn. And that's all from data from the CDC. These are some of the
Wow.
highest numbers reported in the US in more than 30 years. Um, and congenital syphilis is considered an event that should never happen because it's always
Right.
preventable or nearly always preventable as long as it's caught and treated on time. So, as long as we catch syphilis during pregnancy, then mom can be treated with penicillin, and we know to
Right.
check the baby after delivery, and we can treat baby after delivery if we need to.
Right. And it's super easy. It's IV penicillin or IM in the muscle penicillin. And penicillin's an easy drug. It's been around for a while. Either way, it's an injection. And as long as it's treated, then congenital syphilis just won't happen. So, really, anybody who's getting prenatal care, we should never miss syphilis.
Exactly.
Yeah.
Exactly. And if a mom is positive during pregnancy, we will usually evaluate the baby for syphilis by doing blood tests and x-rays, and then usually we'll treat the baby with penicillin as well. Even if the mom was treated, we'll still go ahead and do all this for baby.
Right. And then let's talk a little bit about gonorrhea and chlamydia. The reason we get concerned about gonorrhea and chlamydia is primarily actually around delivery. It can be potentially, it can increase the chances of preterm labor, preterm birth. But the biggest issue around birth is an infection that can develop in the baby's eyes.
Yes. Yeah, exactly. Conjunctivitis,
Mm.
which is an eye infection in an infant from gonorrhea or chlamydia that was passed from the mom during delivery, is the biggest issue. Chlamydia conjunctivitis is actually the leading cause of preventable blindness in the world. And this is why
Yeah.
it's important to be tested and treat mom to prevent her from passing that infection to baby. We also do the erythromycin ointment after delivery on baby's eyes. That's routine standard of care. And that's because it treats gonorrhea. So any gonorrhea that could be passed to baby and lead to an eye infection in baby would be treated by that erythromycin. It doesn't treat for chlamydia though. So it's really important to test and treat mom if she's positive.
Right. So most of us check everybody for gonorrhea and chlamydia, and that can either be done through a vaginal swab or it can even be done through a urine sample.
Yeah, so I'm correct me if I'm wrong, but standard of care now is to do the test that's actually detecting the DNA fragments
Right.
of
Right.
gonorrhea or chlamydia bacteria that are hanging around in the urine.
Yep.
Okay, so if these tests are positive, they're easily treated. And then, you always want to chat with your partner or partners to make sure they get tested and treated as well. And then we really like to retest later to make sure the treatment worked.
Right. So all of these things that we've just mentioned are usually done in the first prenatal visit, or at least in the first trimester. There's a lot that happens at that initial visit. We do a lot of tests at the initial visit, and then we do more going forward. The next thing that we do at that initial OB visit is a urinalysis. And a urinalysis is just that. It's an analysis of the urine and it looks for signs of infection in your urine. So it looks for red blood cells, white blood cells, bacteria. It also checks for things like glucose or sugar in your urine, which could be a sign of diabetes. We also measure protein in the urine. And increased levels of protein in the urine could be a sign of kidney problems. That could even mean that you're at higher risk for preeclampsia. Now, if we see protein in the urine at an initial visit and the blood pressure is normal, that's just something we're going to keep an eye on. Preeclampsia is something that usually happens in the third trimester, not at the initial visit. But protein in the urine by itself is not an indication of preeclampsia, but it's one of the things that we look for in the constellation of things that can mean that the patient's at higher risk. Also, like I said, preeclampsia does not typically happen until the third trimester of pregnancy.
Yes, unfortunately, I know all about that.
Right.
um, But I do know that many doctors do a urinalysis at every prenatal visit to look for protein and to look for glucose and to screen for asymptomatic infections. So you might see your doctor recommending that, but bottom line is you're definitely going to have one at the initial visit.
Right. And then we're also going to do a urine culture. So the urine culture tests your urine for bacteria. And if the bacteria is in high enough levels, that means you have a urinary tract infection. Now, asymptomatic bacteria, which is bacteria in the urine and you don't even know it, you don't have any symptoms. You could have high levels of bacteria and not even know it. That's actually a lot more common in pregnancy. And we don't necessarily completely understand why. We think that there may be some physiologic changes that happen in the body during pregnancy. And the reason that we want to catch this is because bacteria in the urine and a urinary tract infection, so an infection in the bladder, can actually increase the chances of preterm labor, preterm birth, but also pregnant women are at high risk for that infection spreading to the kidneys. It can go up the ureters to the kidneys. That's called pyelonephritis, and that can be a serious infection.
Yeah. Pyelonephritis can lead to bacteremia and urosepsis, which means the infection can spread to your bloodstream and you can get really sick and end up in the hospital with IV
Right.
antibiotics. So that's why it's important to check your urine even if you don't have symptoms.
Right. So we're going to check and make sure that there's no evidence of infection that you're that maybe the pregnant mom isn't even feeling. And then if we do find an infection, we're going to treat that to make sure that we decrease the chances of preterm birth or those more severe systemic infections. Okay, the last two things that we do at that initial visit, or I would say the first trimester, it may not exactly happen at the initial visit, but usually one of the first few visits. One of the next things we do is an ultrasound. You're going to have an ultrasound in the first trimester in order to establish your due date.
Yeah, that was my absolute favorite part. In your first trimester, I mean, for me, I didn't feel like it was real until that first ultrasound. It truly is like a miracle and the best and weirdest feeling to feel that or to see, because you're not feeling anything yet, but to see that little
Right.
baby just growing. And it really doesn't feel real until you get that first ultrasound. So the
Yeah.
best.
I think that it's every pregnant woman's favorite part. An ultrasound
Yeah.
done in the first trimester. It's also most accurate at determining the due date. But in general, the earlier the ultrasound is done, it's going to be the most accurate at determining a due date. So we compare the measurements in that early ultrasound with the due date that's estimated based on your last menstrual period date. And if they're within 7 days of each other, then we just use your last menstrual period due date. But if they're not within 7 days of each other, then we go by the ultrasound date. We change your due date
Yeah.
to whatever the ultrasound said.
Yeah, when I went for that first ultrasound with JJ, he was measuring 7 days ahead, and they talked about changing my due date, but didn't because my ultrasound was later, almost into my second trimester. And one thing people get a little confused about, and I think we chatted about this in another episode, but
Mhm.
with the due date is that if you have a later ultrasound, it may show a different due date, but that doesn't mean that your due date
Right.
changes. That just means that the later ultrasound is coming up with a different estimate. But later in pregnancy, those estimates are less accurate. So we want to use
Right.
that first initial one.
Right. The further along you get, the less accurate the ultrasound is at estimating your due date. So we
Yeah.
don't change your due date based on a later ultrasound. We always keep your due date based on that first ultrasound you had, and then it doesn't change after that. So those are the routine prenatal tests that are typically done at the first OB visit, or at least very early in pregnancy.
Yeah, that first visit is so fun and exciting and all the things. But that's all we have time for today. Thanks for joining us, and we hope you'll subscribe to our podcast and join us next week for the next episode.
Right. Next week, we're going to continue our topic on routine prenatal testing. We're going to discuss the NIPT, which is a genetic test. We're going to discuss gestational diabetes screening and routine third trimester screening tests that are done during pregnancy. So I hope you'll all join us next week.
All right. Sounds good. See you next week. Bye.
Bye.